Welcome to McTox Curriculum, brought to you in collaboration with Western University, University of British Columbia, and McMaster University. This presentation is part of McTox Curriculum built for residents and fellows from PGY 1 to 5. Our topic today is about the toxicologist approach and is brought to you by Bandar Ba. In this video, learners will be able to explain the introductory approach toxicologists use for poison patients, whether it's an undifferentiated presentation or a clear tox exposure. They will also be able to understand and anticipate worst-case scenarios in their patients and to discuss differential diagnosis of common tox presentations. As always, let's start with a case. You have an 81-year-old lady who lives on her own and is brought in by her daughter because she found her mom confused since the day before. She has not been feeling well for the past week with a history of decreased oral intake and vomiting. She's had a previous MI and is known to have hypertension. Currently, she takes aspirin, Lasix, and Ramipro regularly. On exam, you find her mildly tachycardic with a heart rate of 115, stable blood pressure, respirate of 24 with normal oxygen saturations, a borderline temperature of 37.8, and a normal cap sugar. She looks relatively unwell and is mildly agitated. Shown here is a simplified approach to a possible tox case. 5 questions we need to answer, starting with 1, the presenting complaint, 2, pertinent findings, 3, is this poison related, 4, what other diagnosis can't we miss, and 5, what will be the workup. By answering these questions, it allows us to delineate investigations required to reach the diagnosis and prevent missing important findings. Following this approach, we'll answer the questions. 1, this patient presented with confusion. Her pertinent information revealed that she is elderly with a hot and altered condition. This is definitely a common presentation in toxicology. However, it is also imperative not to overlook the possibility of another dangerous diagnosis, like CNS infection, neurosepsis, pneumonia, or stroke. A partial septic workup is indicated, including a CT head, in addition to a toxicology workup, which should include an aspirin level. Blood work for this patient shows that she has a chronic aspirin toxicity secondary to acute kidney injury. Reviewing the case, we have an elderly woman who is dehydrated due to vomiting and decreased intake on Lasix, which worsens her dehydration, and in the meantime is taking aspirin, which you know is renally excreted. She was found confused, tachypnic, and slightly warm. Hitting these key facts, the treating physician can now narrow the differential. A good list for you to make note of is the differential diagnosis for toxin-induced agitation, which includes aspirin, cocaine, anticholinergic, and an acute withdrawal syndrome. Generally, the treatment for agitated patients is sedation with benzodiazepine, both for the safety of the patient himself as well as the treating healthcare providers. It's important to make sure that any reversible causes are thought through and corrected, like hypoxia and hypoglycemia. In certain situations, specific antidotes are required in addition to chemical restraints. Physostigmine is the cure for a severely agitated patient who had an isolated ingestion of Jimson weed, as an example. Moving on to another case. This time you are seeing a 25-year-old female brought to you by EMS after seizing twice in the past couple of hours. She doesn't have any past history and is post-ictal on exam. Her heart rate is elevated at 124 with a pressure of 94 on 48. Sugar is within normal limits. Let's go back to our approach and answer the same questions we used earlier. So, we have a young female brought in with a seizure, which is a first episode for her. As you know, seizure is a common effect of many poisonings, but we need to rule out other life-threatening causes, especially hypoglycemia, stroke, CNS infection, and eclampsia, given she is a female of childbearing age. Our workup, in addition to our toxicology screen, will include an ECG, beta-HCG, and CT head. As you can see, there is a long list of toxins that you need to be aware of that can cause a seizure, including aspirin, lithium, and TCAs. The treatment of a seizure is usually supportive by ensuring airway protection and using benzodiazepines like lorazepam or diazepam, preferably through an IV route. If benzos fail to control the seizure activity, then induction, paralysis, and intubation may be necessary. It's important to note that phenytoin is not part of the algorithm in the treatment of toxin-induced seizures. There are also occasionally situations where specific antidotes are required for a seizure secondary to a toxin. For example, pyridoxine, which is also vitamin B6, is used for an INH overdose, just as bicarb is given for a TCA toxicity. On to our third and final case. We have a 42-year-old suicidal man who ingested an unknown amount of his diltiazem approximately an hour prior to his presentation. He normally takes 360 mg tablets, and he has an empty bottle of 30 tablets with a recently filled prescription. Currently, he is mildly tachycardic with a normal blood pressure and normal physical exam. In this case, our approach won't help with an already identified ingestion. Instead, we need to focus on our toxicology history taking. It's not uncommon to encounter a case like this, where the challenge is not to determine if this is a toxin-induced presentation, as the history is quite clear about the ingestion. However, there is still more that you need to elicit, mainly a what, when, and how much ingested. Information from family and EMS crews are helpful in these cases. We don't know how much diltiazem this patient ingested, or if he was taking his medications as requested. Thinking of the worst case scenario, he could have ingested 21 tablets of his 360 mg diltiazem. Our preparation and treatment should be based on this calculation. In cases where it's clear there's been an ingestion, a specific toxicology approach should be used. Here we start by ensuring the patient is stable, then taking a focus history and doing a physical exam. Decontamination is considered as appropriate. We initiate our workup, and then proceed to the supportive treatment and/or specific antidotes. The final questions we'll leave you with for this module are 1. What are 3 differential diagnoses for toxin-induced hypertension? And 2. When can we say that an ingestion is not toxic? Thanks for watching, everyone.